Welcome again to the Trauma Anesthesiology Society podcast, hosted as always by our partners at Doc Matters. I am Josh Sabenfield from the University of Florida, and I am with Kevin Blaine from Oregon Health and Science University.
Josh and I have been kicking around the idea of a bell ringer, like in anatomy class in medical school, except we wanted to focus on the biggest, most important clinical trials in trauma over the past year. Like everything else, COVID slowed that process down, so we didn't quite make our New Year's deadline, but the idea was too good, so we're going to do it, and here we are. So real quick, here are the rules. We'll give a brief introduction to a clinical trial that was in trauma that was published in the calendar year of 2020. We have 3 trials to talk about, and we included one database study that we really liked. At that point, we'll turn it over to one of our panelists to comment for exactly 1 minute before the bell rings. Then we'll ask the other panelists to summarize her takeaway point, and then we'll move on to the next trial.
So we're lucky enough to be joined by our panelists, Dr. Tiffany Moon from UT Southwestern and Dr. Kathy Kusa from the University of Southern California. Welcome.
Thanks for having us.
Thanks for having me.
Great. Okay, let's talk about our first trial, and this is the iTactics trial. This one is near and dear to my heart because it looks at viscoelastic assays. iTactics is an acronym for Implementing Treatment Algorithms for the Correction of Trauma-Induced Coagulopathy. So not quite as tortured as most acronyms, but kind of. The authors wanted to answer the question, do viscoelastic assays improve mortality over conventional coagulation testing in traumatic shock? They randomized 411 patients to either a massive transfusion protocol based on conventional clotting tests or to a protocol with ROTEM. The endpoint was 24-hour mortality or massive hemorrhage. The authors found no difference in mortality between the 2 protocols.
So I thought this was a very well-designed study. I do think that there is a role for TEG and ROTEM in trauma patients. In this particular study, there appeared to be a benefit in patients with severe TBI where there showed an improvement in mortality. The one issue I had is that these 7 study centers that were involved are very well versed and very well experienced with TEG and ROTEM and run like a smooth oiled machine. I think that there may be variability amongst trauma centers in the US. So in particular at my hospital, it takes 30 minutes at least to get TEG results back. So I don't know how practical it is in that setting, because when we're massively transfusing a patient, using a Belmont or rapid transfuser, we're already correcting for those coagulopathies by the time that the TEG results come back in. But I definitely see a benefit in correcting coagulopathies, and there definitely is a role, in my opinion, for TEG or ROTEM in trauma.
I had a few questions about the study. This is a study that bothers me the most that we're going to review tonight. The first thing I noticed was that the viscoelastic assay had a shorter time intervention by about 21 minutes. What do you guys make of that?
Well, I have a question about how quickly they're getting their results. If they've got to ship the coagulation tests to the lab to get an INR back, that's clearly going to be inefficient, right? Like that's the same as Kathy's talking about sending the ROTEM to the lab. Like you're not going to get the result in time. A better comparison would be a point of care INR versus a point of care ROTEM. Like one of these iStat coagulation cartridges.
I was really surprised that there was no difference in outcomes. Do you think that's because the method of coagulation testing doesn't matter, or was there something wrong with the study design in this case?
I don't think it was the study design, because it actually was really well designed. I don't know if it's the study centers that they involved and there's bias by choosing those particular centers. And then also the sample size isn't huge. It was only 411 patients. So I wonder if they included a larger sample size, if you would see a difference.
Yeah, the other thing I wanted to say is that I feel like the centers that were chosen in Europe were all very well versed in their care of trauma patients. And so you're already dealing with the top tier of trauma centers, and then it's hard to prove that something else can improve outcomes, especially with a relatively small sample size, like Dr. Kuza said. I think the difference may have been more apparent if this had been implemented in trauma centers that were not already so well run, if that makes sense.
Yeah, actually, that makes a lot of sense, actually. And I had one more question. So the authors stated that the viscoelastic testing found more deficits in patient clotting. I was wondering, does that mean that these deficits that were found with the viscoelastic testing compared to the classical coagulation test were subclinical, or are they finding things that need to be treated?
That I was actually not sure about either. And what else I found odd in this particular study compared to other studies is that there was more transfusions given in the TEG-ROTEM group, where previous studies actually showed less product given when using TEG and ROTEM. So I thought that was also odd, and I don't have a good explanation as to why they were transfusing more in that group.
Did anyone else have any other questions or comments about this study?
You know, the question of whether ROTEM and TEG reduces transfusions, it depends a lot on how they're used and how the institutional protocol is. You know, the group in Holcomb's group in Texas, for example, has actually published that they increase some of their blood products like platelets when they use viscoelastic guided guided protocols. So it's a little, I think it's a little bit more complicated. I think it depends on what you're doing with the lab data. But clearly, whatever they're doing, they were using more blood products in this study and still got the same results.
Dr. Moon, we'll end with you. Does this trial make you think any differently about how you use viscoelastic assays in trauma?
You know, I think a viscoelastic testing can be very helpful because it certainly gives you much more information than traditional coagulation testing. But I think the implementation of it is difficult. I think there's a lot of education to train the staff on what the results necessarily mean, and the logistical part of getting the test and getting the result and the setup and everything can be extremely difficult. But I do think that overall it can help guide our specific component therapy in trauma patients. I just think that we need to do a better job of educating and actually implementing this testing.
Okay, Dr. Moon, now it's your turn to look at a trial. Next up, we have the STAMP trial, which is tranexamic acid during pre-hospital transport in patients at high risk of hemorrhage from JAMA surgery. The authors wanted to test whether TXA administered by EMS prior to arriving at the hospital would improve in-hospital mortality. They randomized 899 patients to either a placebo control or to either 1, 2, or 3 grams of tranexamic acid. The primary endpoint was 30-day all-cause mortality. The authors found no improvement in mortality in patients given TXA.
Okay, so this STAMP trial, as Dr. Blaine mentioned, is randomized to two groups of patients: those who received 1 gram of tranexamic acid pre-hospitalization and those who did not. However, they split the patients who received the TXA pre-hospital into 3 subcategories. The abbreviated group got 1 gram of bolus pre-hospital, followed by placebo and placebo. The standard regimen got the 1 gram of bolus pre-hospital, a placebo, and then a 1 gram infusion. And then the repeat regimen got a 1 gram bolus pre-hospitalization, another gram bolus, and then a 1 gram infusion. So there's actually 3 subgroups. The primary outcome was 30-day mortality, which did not differ between the 2 treatment groups. They also had the same amount of blood component transfusion requirements at 6 and 24 hours. However, if you look at the different treatment regimens, the repeat regimen that had a total of 3 grams of TXA did have a lower 30-day mortality. Also, patients who were administered TXA within 1 hour of injury did have a lower 30-day mortality score. So this begs the question, should we give it earlier, and what is the proper dosing regimen? Should it be repeated, and how long and how much?
Dr. Moon, do you have an opinion on the value of this 30-day endpoint? I only ask that because, seems like 30 days is a long time to wait for a result.
Yeah, I thought it was interesting that they chose as their primary outcome a 30-day mortality. I would have liked to see something a little bit shorter. There are some patients in trauma that when they bring them to you that they're not going to last very long, much less 30 days. It would have been nice to see a shorter primary outcome, in my opinion, but we don't have that, not even as a secondary outcome.
So they did report in hospital and 24-hour mortality, but there was no difference in those groups. And I'm wondering if that they chose the 30-day mortality to kind of give time to account for the potential of developing thrombotic complications, PEs, DVTs, that kind of thing. But I do agree, as a primary outcome, a shorter time frame mortality probably should have been looked at.
Another thing that might be going on here, and I don't know if this is the answer, but I think regulatory agencies in the United States like to see a 30-day outcome, which is problematic because I just feel like with trauma, tranexamic acid, even if it's good, is not going to be so good that it'll keep you alive a month. I mean, it might keep you alive in 3 hours to 6 hours, or even 24 hours. But I wonder to the degree to which the regulators are actually driving the endpoints of this trial.
But I also kind of wonder if it's trying to catch delayed death, that even if you save someone on the first 24 hours, if they're going to pass away anyways, was that care futile?
Yeah, I just think a 7-day would have been a nice outcome, because there's people in the first 24 hours that you save. That was no difference between the two groups. 30 days seems a little long, especially in these critically ill patients. Their criteria were severe hypotension or tachycardia, and I just feel like at 7 days that would have been a more relevant outcome.
So at my institution, we do not uniformly give tranexamic acid in trauma. I was wondering if you guys give tranexamic acid at your guys' hospital.
We do at UAE, but it's not uniformly given. It's kind of a surgeon dependent.
Yeah. At UT Southwestern in Dallas, we do not uniformly give TXA to trauma patients. We are trying to get more into viscoelastic testing, and certainly if there is hyperfibrinolysis on the ROTEM, we will give it. If there is no ROTEM, and also this is very surgeon dependent, and it's been less than 3 hours from the time of injury, and the patient has had 3 coolers of MTP, then we sort of, throw some TXA in there.
Kevin, what are you guys doing out in Oregon?
Oh, it's pretty variable out here. I use a lot of TXA myself, but that's your influence, Josh. You're the one who's convinced me to use it more often. But I think all the surgeons are on board with it in a patient who meets appropriate criteria. And because I'm in a referral center in a rural state, a lot of these patients, even these severe traumas, are coming to me more than 3 hours after their injury. So we actually get a fair number of patients that I would say aren't really candidates for TXA. We'd use it otherwise.
So it looked like the difference between the group that received tranexamic acid and the group that didn't was non-significant. I was wondering if anyone thought that this study should be used to justify whether or not a clinician gives tranexamic acid to their patient, or if this just is kind of another stone in the water.
So I don't necessarily think this study should be used to make clinical decisions. I think there's some issues with the study design. And then also, what I found to be very odd in this study is that there wasn't a ton of patients who were bleeding, and only 34% received blood transfusions and had overall low injury severity. Even looking at the subgroup that looked at patients who got MTP, it wasn't even 100 patients. So I don't think we can kind of generalize the results from this study and base our clinical practices based on that.
I agree with Kathy. I think from speaking to my trauma surgeon colleagues, they sort of have a sense of when a patient has severe hemorrhage and they believe that TXA will additionally benefit. And they're not really going off studies per se, but sort of their clinical assessment of the situation, whether they're able to get control of the bleeding, how many coolers of MTP we've gone through, that sort of clinical gestalt, I think, is what surgeons are basing their request for TXA from, not necessarily studies.
Okay, 2 more studies to go. The next one is the non-flail trial from the Journal of Trauma and Acute Care Surgery. The authors tested whether surgical fixation versus non-operative management of rib fractures would result in less pain. The primary endpoint was the numeric pain scale, the 0 to 10 or the 1 to 10 scale. At 2 weeks after the injury, they randomized 110 patients. They reported that pain was significantly lower in the surgical stabilization group, 2.9 of 10 versus 4.5 of 10.
Yeah, so I definitely think that there is a role for surgical rib fixation in patients with non-flail injuries. Um, Previous studies have clearly demonstrated a benefit in patients who have flail chests and patients who can't be liberated from the vent with surgical rib fixation. And this study does show an improvement in pain control and respiratory function at 2-week follow-up, and then fewer pleural space complications. Even though it was not clinically significant, the surgical fixation group also showed a decrease in narcotic consumption, which I think if they had a larger sample size than 110, you may see more of a clinical significance in that. But I think we have to do additional studies to kind of fine tune which patients would most benefit who have non-flail chest from the surgery. So for example, if a patient is stable, pain is well controlled, they're ambulating, they may not necessarily need the surgery. Whereas if you have a patient who has impaired pulmonary function, in a lot of pain, they would definitely benefit from surgical rib fixation.
So I didn't have as many questions about this study. I thought it was a lot more straightforward. I don't know if anyone else had any questions about it.
I agree. It was very straightforward to me.
I just had 2 comments just reading through this study. So one was the small sample size, and then a majority of the patients that were operated on came from 4 out of the 12 sites. So you're looking at patients who are operated on in centers that have a lot of experience with doing this surgery. So I'm wondering if the results can necessarily be generalized to all trauma centers. Um, the other thing that I noticed was that there was no mention of chronic pain patients or factoring that in. It wasn't an exclusion criteria, and I don't believe they accounted for that as a confounder or variable. But I think patients who are on narcotics or pain medications at baseline would definitely affect some of the findings in the study.
Yeah, that's actually a pretty interesting point, and something that we deal with. Well, definitely deal with in Baltimore, but I deal with someone here in Gainesville. Dr. Moon, your verdict: should 3+ rib fractures be surgically stabilized?
Yes, I mean, despite the results of the study, I still think that these surgical fixation of rib fractures, from what I've seen clinically, leads to a much better pulmonary outcome and pain control in patients. Certainly, if I had this injury, I would want surgical fixation.
Okay, great. Last study, and we really wanted to get a 4th clinical trial, but we couldn't find a good clinical trial, but we did find this really good retrospective study, and it was too good that we just couldn't pass it up. It's titled Pre-Hospital Critical Care is Associated with Increased Survival in Adult Trauma Patients in Scotland. Using retrospective data, the authors tested the hypothesis that physician presence on retrieval runs might improve 30-day mortality. they had a data set of 17,757 patients from the Scottish Trauma Audit Group. They reported that the odds ratio of death was 0.56 when a physician was present on scene.
I mean, the results are not surprising to me. I could have guessed them from the title of the study, but certainly it's not that it does lead to an improvement in care. It's just that I don't know, however, in America we would make this happen with the already limited resources that we have. But certainly the results that are presented in this paper to me are very predictable.
Yeah, so I really thought this was very interesting. It makes me think of the current study in Philadelphia where they are randomizing scoop and run versus stay and play. And it makes me think. And I was wondering what you guys thought about the study, whether it was having a physician on the pre-hospital team or the increase in pre-hospital interventions or some sort of complex interaction between the two that led to the improvement outcomes in the study.
I mean, I agree with Dr. Moon where having a physician on site is very valuable. And it's obviously a more experienced person providing acute care in a more timely fashion compared to, EMS personnel. Um, but in the US, we really have limited resources. And in the US, we have much higher trauma numbers than in some of these other countries that have physicians as their pre-hospital team. So I don't think it's necessarily feasible or plausible to, send a physician to respond to trauma. The other issue in the US is um, physicians don't necessarily have hospital privileges wherever the patient is being transported. So that's another barrier in the US.
Yeah, I was also noticing that the paramedics had I thought it was a pretty low exposure to severe trauma. I believe they said it was 0.3% of their trauma in Scotland. I was wondering if that would affect the generalizability of the study outside of Scotland.
Well, you do kind of wonder what their training and exposure would be. And if the paramedics there saw trauma more frequently, would the benefit of having a trauma physician go down just simply because the pre-hospital providers had a little bit more comfort with that care? I don't know. I'll be honest. I don't know how Scottish EMTs are trained. So we're kind of an American focused group in this particular conversation. So maybe if some of our listeners in the UK can fill us in, that'd be very helpful.
I agree that there is a benefit to having a physician in a pre-hospital critical care team. I don't know how feasible that is in the US. Um, there's definitely a role for them. I believe in situations like mass casualty events where you would send a physician to a remote location to tend to the patients. One example is the London bombings where you couldn't get patients out and they sent physicians to provide care and resuscitation to those patients just because they physically couldn't get them to the hospital. So that's a very valuable role that physicians have. And there's no doubt that an experienced physician would improve patient outcomes, but I just don't know that it's feasible in the United States.
Okay, well, that should wrap up our bell ringer for 2020. Thank you again, Dr. Moon and Dr. Kuza, for joining us. We hope to have you back at some point in time. Kevin and I would definitely like to make this a reoccurring session. If anyone in our audience would like to submit studies for 2021, we will definitely take suggestions. Thank you again, Doc Matters, for hosting us today and our panelists for their time. We hope this has been educational. We look forward to the discussion.
Thanks, everyone.
Thank you so much.